enjoyed the last session a lot. Hopefully this one will be as useful as the last one, I hope. So from my point of view, I've been asked to talk about revision knee. I'm starting with the basics and then we will work up. So from my point of view, the principles of knee revision are very simple. I've put in red the most important bit. The most important bit in any revision knee is preoperative planning. You know what you're going to do, you know what to expect, then the knee replacement, the revision will be simpler. If you go in there not knowing what you're going to do, you will run into significant problems. And with any revision surgery, it's not about having plan A, but also having plan B, C, D, and E. So when we look at any knee replacement, we need to work out why we're doing it. That's really important. And then how we're going to approach that knee. So incision and approach is number one. How we're going to take the implants out. Debridement, whether it's for infection or not, is an important part of any knee revision. Getting the knee right and balancing it, and then managing the defects, which most people get excited about, but is not as exciting as we all think it is. It's very simple. And then the important bit is putting in the implant. So with the planning, the most important thing, like I said, is the reason for revision. So obviously the common causes are common. Infection is obviously number one, and then aseptic loosening is number two, generally in the UK, certainly. So those are the two that you need to think about how you're going to manage. So if there's infection, then your main goal in the revision is to deal with the infection, whether that's a single stage or a two-stage revision, versus something with aseptic loosening where you're going to have bone loss as a result of the implants being loose, mobile, and may cause fractures, may cause bone defects, and therefore from your point of view you need to be able to have a system and a way of thinking when you're doing these operations to deal with that. Instability is important as well, and probably the most important thing to examine in the clinic. The reason for that is that will determine what level of constraint that you're going to use for your revision knee, and we'll come to that in a bit. Remember the most important thing, whether it's malalignment, instability, loosening, stiffness, they could all occur with infection as well. So always, all revisions, make sure your implant is not infected, because the worst case scenario is to do a beautiful operation and then find out that you've got infection in it, and it's very important. So in the UK, this is a table from what we call our National Joint Registry. It looks at the reasons for failure and the reasons for people doing single stages. Actually, overall, you can see the biggest number here. Overall, the biggest numbers are aseptic loosening, instability, and then for people who do two stages, obviously that 75% of the time that's done for infection, okay? So it is important in this scenario that you work out exactly why you're going in there and always think about infection. So your primary goal of your revision is to provide stability to the patient. So whatever you do, the knee must be stable. Following that, function, which comes with range of motion and patella tracking. And naturally, if you restore the alignment, you'll get the two above as well. You'll get the range of motion and stability. And the important thing at the end is for it to be infection-free. So from my point of view, stability means what level of constraint do you need to ensure that the knee is stable. So that comes with the assessment of the ligaments, assessing the level of constraint in the implant you're revising, and then deciding how you're going to constrain your knee. So generally in a revision practice, you aim for one level above. Okay, so if you've got a CR knee, then you want at least a PS, if not a high post semi-constrained type knee replacement. If you've got a high post already, then you may have to think about proceeding on to a hinge type knee replacement. But generally, as a rule, you're looking for one level of constraint above. But remember, with constraint comes downsides. The more constraint you put onto a knee, the more bone stock you will lose. So a hinge typically has significant bone stock removal for either the box that the hinge is in or a big cut off the back to accommodate the hinge. And this also means that you end up applying more stresses to the bone cement interface at the stems or the sleeves or whatever you may be using, which means that you get an earlier loosening and a shorter survivorship with a revision knee. So always find the balance between your constraint and your bone stock. So level constraint, like I mentioned, you've got the CR, which is your least constrained knee, your PS, followed by your semi-constrained, which can be a high post or a even more congruent polyethylene. And then you've got your rotating hinge or endoprosthesis, where you have a link between the two systems. So you've got a join between the tibia and the femur, and obviously the most constrained is an arthrodesis. So for those who don't know what a semi-constrained is, so you can have either a high post, which is what most of us think about, so a bigger, taller post that controls stability, valgus and varus in the coronal plane. But you can also get a much more congruent poly, like I mentioned. So you can see here how the poly provides that additional stability. So typically a semi-constrained knee replacement, you're looking at LCL injury or a stretch or attenuation, moderate bone loss, and some people in the book say MCL attenuation. I would say that is feasible, but generally as a rule, your MCL is extremely important, and just be wary that if you're concerned about MCL stability, then you should be thinking about a hinge. And majority of the time, your hinge is your bailout for MCL. It's very rare that you downgrade, and from that point of view, if you do that, then you are likely to put significant pressures on your implant if your MCL is incompetent and you're not using a hinge type prosthesis. So the rotating hinge gives you global stability. It's very common if you've got MCL incompetence. We tend to use it in severe bone loss. Obviously, we can combine that rotating hinge type prosthesis with endoprosthetics, and it obviously deals with significant flexion extension gap disparities. So when we're doing the knee replacement and we take out the implant, obviously our priority is to take the implant out with as little bone loss as possible. There are lots of different techniques that you can do for that, which we'll come to later. But essentially, bone loss on the femur generally as a rule is relatively easy to deal with, and on the tibia, harder to deal with. And that's simply because the majority of the muscles attach to the tibia, whereas the femur, you can essentially debride and remove significant amounts of the distal femur, and the soft tissues and the muscles predominantly attach higher up or up at the pelvis. So the femur is much easier to deal with when you've got defects. The tibia is much harder. Obviously, at the front, you've got the tibial tuberosity, which obviously is your extensor mechanism. So therefore, you have to preserve that. And posteriorly, you've got the neurovascular structures. So it's much harder to deal with those defects posteriorly. And also, you've got the tibiofibular joint proximally, which makes it much, much harder to deal with the tibia in general, particularly if the defects are large. Our ways of dealing with the defects are, we've been dealing with defects for many years, but in modern times, we have lots of new fancy gadgets that we can use. So we can replace or fill the defect with metal, we can fill it with cement, or we can fill it with bone graft. And I put brackets around bone graft because in this day and age, bone graft is becoming less used, and the reason simply is that we do know that bone graft can resorb, and you can lose the stability that the bone graft initially provides, and the bone graft can fail as well. So from that point of view, that we're slowly, a lot of knee surgeons are moving away from bone grafting. So with a bone defect, we tend to discuss it with whether it's contained or uncontained, whether we're going to fill the defect or we're going to ignore it and bypass it. So those are your general rules with any defect. How are you going to deal with it? Firstly, is it contained? I.e., is it rounded? Can you fill it without the contents that you're going to fill with leaking out? So this is similar to any defect. So when you talk about the acetabulum, we all know Proposky's classification, which is very complicated and difficult, but actually his classification is very simple. It's where is it contained, is it uncontained, and that gives you a flow chart as to how you're going to deal with that defect. So from our point of view, if we're going to fill it, we can fill it with cement, we can put bone graft in, we can put an augment in, which is essentially like a metal wedge or a block, that will fill the hole, or you can use something called a cone, which we'll come to. The other option is to ignore it. So we have lots of defects proximally here on this X-ray, and we can essentially ignore those defects and use this part, the metaphysis, to hold the knee implant and ignore these defects and bypass it. So we're not relying on the proximal bone to hold our knee replacement, so we can bypass it. So fixation-wise, from my point of view, this is probably the most important paper from your point of view when thinking about how to deal with a knee replacement. We define the fixation of a knee replacement, a revision, by the zones. So we have zone 1, which is the joint surface, zone 2, which is the metaphysis, and zone 3, which is the diaphysis. So in a revision setting, we ideally want 2 zones of fixation. So typically in a revision scenario, zone 1 is compromised. So here you can see that the bone distally has disappeared, particularly here laterally. So therefore we can't rely on zone 1 for fixation. So we have to go to zone 2 and zone 3. So in an ideal world, you need a minimum of 2. In an even better world, you get all 3 in a revision scenario, okay? So in this scenario, you can see that we've got contact with the tibia proximally here in zone 1. We have cement in zone 2, holding this part of the stem in the metaphysis. And then we've got a stem which is in the intramedullary canal, providing contact on either side. So here we have 3 points of fixation in the tibia. So as I said, zone 1 generally is compromised. Generally, if we've got a defect in zone 1, they're usually small and easy to manage, and we can just fill them with cement. So generally, the surgeon will either do a lower cut if it's a global or a large uncontained defect, drop the tibia. Obviously, you can't keep dropping the tibia because otherwise you'll be into the fibula head and in dangerous territory, but you can lower your tibial cut. You can consider cutting as normal and filling the defect if it's contained with cement or bone graft. As I said, we tend to go away. However, if you get the scenario where you tend to get a isolated uncontained defect, so this is quite common, for example, in the scenario of a uni to a total knee replacement, where you've got loosening of the tibial component, you get loss of bone stock medially, whereas laterally you have good bone stock. Generally, these patients are younger patients because they had their unis in their 50s, they're having their primary in their 60s or 70s. So you want to preserve bone stock. You can't cut down at the level of where this augment is because you will lose a lot of proximal tibia and you'll compromise the tibial tuberosity attachment. So what we do is we maintain our bone stock laterally, we cut, make a step cut as we call it, and apply an augment to that medial defect. And that allows us to get, again, a zone 1 fixation, even though that's with an augment. We have bony contact alone zone 1, and then we cement distally to get zone 2. Zone 2, from my point of view, in revision surgery is the key, okay? It allows closer fixation, so it's biomechanically more stable if you've got zone 2 fixation. If you get good hold in the metaphyseal zone, you can adjust your joint line much better, it's more accurate. You can use shorter stems because you've got better hold in zone 2, and that is important because a lot of stems do cause stem tip pain in the tibia particularly, so you can get pain at the tip of the stem, which is sometimes very difficult to deal with and can be quite debilitating for the patient. It also means if you get metaphyseal fit, you need less need for offset stems, especially the femur, and metaphysis is a cone shape. So if you get a good press fit in the metaphysis, you will get good rotational stability. So it's much better, again, for adjusting your external rotation on your femoral or your tibial component. What's the best fixation in zone 2? That's controversial. There are different ways of doing it. We can simply put if we've got reasonable zone 1, we could put a tibia with a long stem and cement around it and cement into the metaphysis. This is a very good system and works very well. It's cheap, it's readily available. You can put antibiotics into your cement. It's easy to do as a technique, but if you were to go back in, taking all that cement out of the tibia is extremely difficult. okay, and makes revision very hard if we're cementing into the metaphyseal bone. And we've all been there with the revision hip where you have a fully cemented stem and you're trying to remove cement from a femoral stem when it's well integrated. That's even more difficult when you have an intact tibia and you're concerned about breaching or damaging that proximal tibia. The alternatives are something called a cone or a sleeve. Now, both of these do similar jobs. Both are more expensive, obviously, and the companies absolutely love you using both of these. You tend to use less cement with a sleeve because a sleeve is essentially an uncemented device. It uses HA coating to bond to the metaphyseal sleeve and gives you biological fixation. So from that perspective, gives you better stability, less likely to loosen, it's press fit, and so works well. So I'm going to go through both of those in a bit more detail because this tends to confuse people a little bit as to what they are, and I'll come to that in a second. So before we move on to cones and sleeves, we'll just mention zone 3. And zone 3 is obviously the diaphysis, and the idea is you can use a cemented stem like we have here or an uncemented stem. Again, it depends on your metaphyseal hold. If you're concerned that you don't have good metaphyseal hold, you will need better diaphyseal hold, which usually means you end up going longer on the stem. Obviously, if you use a sleeve or a cone where you have good press fit at the top, then you can go shorter with the stem because it's less important. And the way I think about it, it's a bit like a keel on a boat. It provides the stability. The longer the stem if you're unstable on rocky water at the top, you need a longer stem to prevent toppling from side to side, varus and valgus. Always be wary about going with a long stem. Number one, you're more likely to fracture. Number two, you're likely to get stem tip pain. And number three is particularly in the femur has a bow anteriorly. If you go long, you will engage in that bow, and there is a tendency to move the implant up or down depending on how you engage. So it will affect your flexion gap or your extension, your flexion gap if you're too anterior or too posterior, and that will lead to a gap balance issue, and I'll come to that a bit later. So this is a cone. So those of you who've not seen a cone, this is trabecular metal, porous metal, whatever you want to call it. It's essentially similar to trabecular bone. It has that sort of density, so it allows bony ingrowth. So the way I think of a cone is essentially a bone graft. It is a bone graft with porous metal. Okay, so you have a defect, you put this in, and you can change what is a uncontained defect into a contained defect, or you essentially create bone graft, so you've got a smaller defect. Generally, if there is a defect bigger than the cone, you have to have a combination of press fit, where the bone integrates into it, and cement sometimes around the top, just to create a solid fix. But remember, with a cone, it creates bone graft. It's not a part of the implant, so you then need to cement your tibia and your stem through the cone. So the inner aspect of the cone will be full of cement. So you get bony ingrowth from here to here. So you've got one interface, which is your cone and bone interface. And then you've got your cement and cone interface. And then you've got your cement and implant interface. So it's one of the concerns that people have with the cone is you have three interfaces: bone to cone to cement, cement to stem. Okay, so this creates a bit like a composite beam in a hip. You have lots of different interfaces that potentially could go wrong. So people are worried, and obviously you then fill this whole vacuum or void with cement. So again, you get the benefits of cement and the disadvantages of cement. A sleeve is very different. So a sleeve is essentially a part of the implant. Okay, so it is the implant. Okay, so a cone is a bone graft, and then you cement the implant into that bone graft. The sleeve is part of the implant. So when you try and remove it or take it apart or have to put it together, the sleeve is essentially the implant. So the way I look at it is a bit like a karai hip. I know many of you may have done uncemented hips. You can see the jagged edges that you normally would see with an uncemented hip prosthesis. And this is a press fit type effect. So a bit like the top of a hip replacement. When you place the stem in, you push it out until you get full contact. The way we test the sleeve is essentially bang it in, and then with the handle that you're holding, with the sleeve in, you pull up or pull out and see if the sleeve holds. If the sleeve holds, you've got good enough control. So the initial part of when you put them in, it's press fit. But like a hip replacement, there is HA coating proximally, and the HA coating will then create a bony bond after 2 weeks or more. So it's more expensive, but you see this beautiful shape that you get in the tibia here, where you get these jagged edges, which gives you that amazing press fit and rotational stability. They're generally oval, not round. That oval shape gives you the ability to get good rotational stability. So a round sleeve would rotate. This is much harder to rotate. It gives you significant metaphyseal contact. So you've got contact all the way. But generally, we only use proximally coated because obviously if we ever had to remove it, we don't want this bonded all the way down to here, which would be difficult. And generally, because you've got such a good hold at the top, the stems can be shorter, and therefore you get all the issues. You don't get all the issues that you would normally get. So here's a sort of difference between the two. So you can see that here, the stem, the tibia, and the sleeve are all as one. Here, actually, the cone here is completely separate and needs cement inside this to hold this construct into the bone graft. So you can see an example of a different cone in the femur going in and trying to deal with an anterior defect and maybe even a condyle defect by giving these two flanges on each side. So, like I said, the sleeve looks like a karae. This is my attempt at trying to draw a sleeve. You can see smooth, jagged edges on either side, okay? With the defect in the sleeve, we basically ignore it. So in this diagram, which is from the Optec, you can see that actually the bonding is here, and all this defect here is not relevant. We have good hold here, we have good hold here, we have good press fit here, and actually, amazingly, a sleeve works on the principle that it is ovoid, so it needs medial to lateral fit. If there's a defect anteriorly, posteriorly, both in the tibia or the femur, a sleeve will still hold. So sleeve requires the condyles, but you can have a large anterior defect and a sleeve will still do the job. So it's very good as long as you've got medial to lateral support. So here's an example from my point of view of the different ways of using a sleeve. So remember my zones of fixation. So we haven't got a zone 1 here. We've got zone 2 fixation here and zone 3 fixation. In this scenario, which I don't normally use, we have zone 1 and zone 2. This is a very expensive way of doing it. In this scenario, a tibia, proximal tibia with a stem would have been just as sufficient as a sleeve with a stem. So typically, if your zone 1 is okay, most of us will use zone 1 and zone 3. So we use that keel, like the ship, the keel analogy. We've got a long stem, provide coronal plane stability varus valgus to our tibial tray. So we use a stem and a tray, and we use cement to ensure we've got a good zone 1 fit. And very occasionally you get a scenario where you need to use all 3 zones. And if you get the benefit of all 3 zones, that's a fantastic operation. You've got cement that builds your tray, zone 1, you have a sleeve, zone 2, and you have a zone 3 stem. But you can see the stems can be shorter and don't need to go longer because we've got such good hold you can see that on the lateral view, how good a press fit we've got. So even though in this view, it looks like the sleeve is smaller, actually we get fantastic hold without having to go right out to cortical bone. We do not need to go all the way to cortical bone. So we can leave some of the metaphyseal bone, which means that if we do come to a revision and we remove it, we can still go bigger. Tibia, we've mentioned, is difficult. There's lots of classifications looking at this, but essentially the tibia is difficult because obviously we've got the metaphysis, diaphysis, and we've got the tibial tuberosity at the front, which is the main part of any knee replacement, is the extensor mechanism. So we can get defects where we use a cone. Here's an example of partly using a cone to get bony integration lower down here, and we use cement at the top to provide a rim support, so therefore our tray can sit evenly in zone 1. So we're going to have zone 1 fixation with cement on top of this cone. We're going to get zone 2 fixation with cement in our tibial stem, which goes down, and we'll get zone 3 as well. Amazingly, we can get horrible x-rays like this. This is one of my specials. You can see how much bone loss we have. We have a non-union of the tibial tuberosity from an infection and a traumatic injury. And yet we've managed to put a sleeve in and get bond and bind here, amazingly. And it works really well, despite the fact that you would say that there is not a lot of proximal tibial bone there, but the sleeve is very good at achieving bonding. Similarly, we get, unfortunately, the scenario where zone 2 is potentially not usable because the bone is infected or there is a significant deformity there. And in that situation, because we can't get our zone 1, 2, or 3, we can't get our 2 zones, then at that stage, unfortunately, we do have to then go to something bigger. This is why endoprostheses are still under consideration, because what you're relying on is only a zone 3 fixation with cement. What most of the endoprostheses do have is this collar, which varies from implant to implant, but the idea is you get bony integration into this, which is trying in a way to get some degree of zone 2 fixation if they can. So I'm just going to talk very briefly about a knee replacement, revision knee, and how I approach it. So the incision and the approach, always use the most lateral scar. Unfortunately, if you use a medial scar, the bit in between will die. So always go for the most lateral scar. You don't want this. This is bad news, and we don't want that. Your plastic surgeon or your revision knee surgeon will be very unhappy with you. There are lots of interesting ways of getting into the knee. Cutting the rectus, snip, lateral release, patella turn down, quadricep VY-plasty for really difficult, stiff, tight knees. My honest answer to you is you don't really need them. They're very, very rare. And if you are going to need something, certainly in the UK, the commonest thing that we use is a tibial tubercle osteotomy. We use that, we make a cut to the front, and we take the extensor mechanism off. Now, that sounds like a horrendous thing to do because you're essentially destroying the extensor mechanism, and I've just told you it's so important. Actually, it works amazingly well. The most important thing here is not to release the hinge. So you can take off one side and you open it up like a book. But if you leave the hinge intact, then essentially the retinaculum on the lateral side is intact, and therefore the tibial tuberosity will not migrate northwards. So when I do patellofemoral work and I do medializations, then I leave the medial hinge intact and I medialize the tibial tubercle. I put a single screw and I let them flex and bend straight away. And as long as the hinge is intact, then the tuberosity will not elevate. And this is a really simple and easy way to enter your knee, because essentially you reflect the whole quads mechanism. The other benefit is that this is bony healing. So I showed you that horrible x-ray of the tibial tuberosity not healing, but actually amazingly they do heal. And you're getting bony healing, whereas all those other horrible things that we used to use, like rectus snips and patella tendons, they're all soft tissue procedures, and therefore the healing is compromised. The quadriceps is compromised, the extensor mechanism is compromised, and you have to essentially adjust their post-op protocol. Whereas with this maneuver, you can let them flex from day one. They can bend from 0 to 120 degrees without a problem, and it will not move if you leave the hinge intact. So this is, for me, the bailout for a difficult knee replacement, or in a scenario where you have a long cemented stem where you're surrounded with cement. And a bit like a femur, in a femur we talk about extended trochanteric osteotomies. This is an extended tibial tubercle osteotomy. So this allows us access to the implant, and then we can chip away at the bone, but we leave the entire tuberosity intact, and then we close the book afterwards. Actually, with time, as I've done more and more of these, I now I'm only at the stage now where I put Ethibond in. I don't put screws or wires or any of those sort of things. Certainly some of my colleagues who've been doing it for 20 years, they don't put anything in. They don't even bother stitching it together. They literally just close it and leave it alone. And amazingly, it all heals up. I've not been brave enough to do that yet. Implant removal we talked about. So you can use saws, you can use flexible osteotomes. We sometimes use something called the double bonk technique. So many of my trainees use this, where we use an osteotome on either side and we hit simultaneously on both sides, so we get an upward or a downward movement of the whole implant. The other good tool that I use quite often is something called a jiggly saw. So that's a bit like your wire saw. You can use that under the implant. That creates a really good way of removing cement whilst not removing bone. And then obviously you have specialist implant kits which you can use. For me, this is the most important step, whether it's infected or not. The debridement is key. When you're a trainee, the bit that you get to do first is put the implant in. The bit that you get to do second is the actual preparing of the bone. And the last thing that your consultant or your trainee, that your consultant will let you do, is the actual debridement and the approach. That is the hardest bit of a revision knee. It's approaching, knowing the layers, developing your planes, exposing the knee, and developing those techniques. And that's whether it's revision hip or knee. The approach is actually the hard bit. The actual, once you get to the metal bit, is actually relatively straightforward. So from my perspective, the most important thing with a revision knee is gap balancing. Okay, so it's restoring the joint line and making sure your flexion gap and your extension gap are the same. So your extension gap is between your distal femur cut and your tibia, and your flexion gap is your posterior condyle of your femoral component and your tibia. And those two need to match up. Generally, in a knee replacement, when most people do a gap balance technique in a primary knee, they tend to do their extension gap first because they've done their distal femur cut and they've done their tibial cut and they've got an extension gap, and then they match that to their flexion gap. But in a revision scenario, generally you have distal femur loss or tibial loss. So it's difficult to judge your extension gap. So therefore, most people go to their flexion gap first. And we'll go to that in a second. So when you start with any revision knee, always look at the size of the implant you're about to take out. Generally, as a rule, the implant you're taking out is usually, you will know whether it's undersized, oversized, or the correct size. So the minute you know that, you know your front to back diameter of your femur straight away, which allows you to guesstimate your flexion gap. So if this was a size 4 PFC, then my equivalent in my revision system is the size of the femur that I'm going for. So I then already have a good idea of what my size of my implant this way is, and therefore I have a better idea of what my flexion gap is. Similarly with the tibia, you want to know roughly what it is. If you have malalignment, then actually when you go into your knee replacement, you will know where your defects are going to be. So if your tibia is malaligned, you know that when you make your tibial cut, you're going to have to take more bone off laterally here to get this tibia to be straight and down the fairway. Obviously, when you make that cut, like I said before, ideally you want bone preserving. So rather than making this blue line cut and cutting the collateral here, the LCL, we go for a slightly higher cut. So we take less bone off the lateral side, and rather than taking bone, we try and build up the medial side. So here we could use an augment, here you could use a sleeve, we could use whatever we want to lift up the joint line and therefore take less bone off the lateral side. So again, these are the techniques we use, the devices we use to allow us to preserve bone, particularly on the tibia side. Remember, malrotation is really important. One of the commonest reasons for a painful knee replacement is internal rotation of the component. And as you all know, that's typically common in the valgus knee because you have a hypoplastic lateral femoral condyle. Most people reference off the posterior condyles. This condyle in a valgus knee is deficient. So if you then apply your condyles here and you rotate 3 degrees to that, your component will still be internally rotated. So when you come to the revision scenario, guess what? If it's internally rotated, your flexion gap is at an angle, which means this bone here in the blue triangle is missing. So to correct that flexion gap, you've got to take more bone off the medial side and somehow build up the bone on the lateral side. So we're trying to deal with this deficiency here, okay? There are lots of ways of calculating the joint line, both mathematically, reference points, etc. The honest answer is most knee surgeons don't use this. We use it for research. What we tend to use intraoperatively is the meniscal skull. So we use the scar that's left behind, we look for the meniscus, and we know where our joint line is. So we want to, in the first setting, start with the tibia, build the tibia up, and estimate the poly that will give us our joint line at the level of the meniscal skull. So generally, we build the tibia up, measure our poly, and then we've got our gap. Okay, so we then measure our flexion gap first, which is a tibia and a poly, and then we do our extension gap, typically in a revision knee. Here are some of the examples that you can do, just how we build the tibia up. So sometimes we use a sleeve, sometimes we just use a simple stem, sometimes we even need a little offset because there's a little bit of tibia vera or valgus in the knee. But essentially, we build up the tibia as a trial. This gives us a flat surface to work on. We can set our rotation off this, and we can measure our flexion extension gap off this too. Then with the femur, we flatten our femoral distal cut, and then we look at our gap. So here I've tried to demonstrate in a way how we measure our flexion gap. So when we take the implant off, we know it's roughly a size 5 or 6 implant, for example. We can then put on a trial if we want. We know that most implants are somewhere between 9 and 10 millimeters deep at the back, and therefore we can then estimate how much space we've got between our tibia and our posterior condyles. That gives us our flexion gap, and then we try and marry up our extension gap. So we then bring the knee into extension, and then generally as a rule, because we're deficient on the femur, we end up having to distalize the femoral component to match our flexion gap. So if our flexion gap is 8, our flexion gap here is 8, and our extension gap is 10, then we need a 2 mil distalization of the femur to make this 8 and 8. Okay, so the most important thing in a knee function is this, the posterior condylar offset. Patients vary enormously in their condylar offset. You can see in this patient, it's almost double the width of the femur. Other patients, it's much smaller, but the key is to make sure you restore that. Otherwise, you will get a flexion extension mismatch, and that is really important. So here you go. This is me measuring my flexion gap using a spacer, using my component or my block to estimate the gap, and then I would do the same in extension and get these two to marry up. So this will allow me to put little augments on the back or augments on the back condyles, and basically either drop or increase the size of my component to balance those two gaps. So here's an example again. You use an augment posteriorly because there's deficiency here, and we can put a distal augment as well to distalize the joint line if we need. Remember, gap balancing is particularly difficult when your collateral is injured. So this is a scenario where the surgeon has not recognized the fact that the collateral is gone. Almost certainly, if you're putting in a poly more than 15, 16, 17 millimeters, that is almost impossible if your collaterals are intact, unless you've taken a lot of tibia, okay? So remember, you're replacing the joint line. So at the moment, this patient's joint line is about 2 centimeters above their femoral head, which is way too high. And to get a poly in this size with that tibial cut, almost certainly the collaterals are gone, which haven't been recognized. So it is important that if you ever put in a very, very big poly, just think, are the collaterals intact? Because if they are not intact, then your gap will be enormous, and then you will struggle to get your balance. And that is it. I am finished.
Thank you so much, Professor Nawaz, for this very interesting talk. Thank you so much, sir. Dr. Ahmed Sheikh is the moderator with you, sir, for waiting for any questions to Dr. Nawaz.
Thanks so much for this heavy and conclusive work. It's a very good thing that we are revisiting again the totaliatoplasty and revisions. As you said, we started this 13th of June last year, so it has been a long time.
Yeah.
So it's very good timing that we have this deep insight again. So, dear colleagues, if anyone got some questions, shall we just waiting for any common questions?
Stunned silence.
No. Some colleagues just thanking you for this, of course, and
no problem. No questions. Very good. That means I've done my job properly. I've taught them how to do a revision knee.
I have a question for you. I have a question for you, Dr. Nawaz.
Okay.
Is there a limit for bone loss that can be reconstructed by cones and sleeves and the trabecular metal?
I would say that, so the slide where I had that classification about the tibia,
yeah.
So from my point of view, the sleeve, when you get used to using sleeves, you know roughly how deep they are. And we have the ability to use fully porous sleeves. So in a situation, particularly where I have patients with fractures just below the stem of a primary knee in the tibia, that is sort of mid metaphyseal zone. So there you are pushing the limits of the sleeve. But certainly, the reason I show that that picture with the osteotomy that had not healed, I wanted to show that to show how much you can get away with a sleeve. It is quite incredible where you can get bonding with very little bone and the sleeve will hold. It is quite incredible. Generally, obviously, with the sleeve, you've got to go longer with the stem. Obviously, the advantage is you go shorter with the stem with the sleeve, but obviously, the less bone you have metaphyseally, then the longer you go with your stem. So you're almost treating it like the cone scenario again. You're not very good metaphyseally, so you need better zone 3 fixation. So if I'm using it with, you know, a mid metaphyseal fracture and I've only got half my sleeve in, then at that stage I'll go longer with my stem, and that will give me better zone 3.
Have you been first, sir, during your revision with some cases that you decided to go with distal femoral replacement, such like the tumor prothesis?
Yeah, I mean, there are certain situations where a distal femur is definitely right. The commonest scenario for me is malunions are difficult. Typically, when the distal femur, particularly with a fixation, is translated, that happens quite often because they're malreduced. They make it plate shaped, but the whole femur moves across. Then my sleeve cannot fit in the right place because my sleeve wants to go in the middle of the femur, which is here, and my stem wants to go here. So suddenly we've got a big offset scenario, and the most offset systems will, with most malunions, the offset is more than that. You need a centimeter, 1.5 centimeters to get the proper offset to get when the distal femur is malunited. Scenario in a low morbid patient, you know, elderly, I would probably go distal femur in that scenario. And you can get distal femurs with very small resections, like 8 centimeters, 7 centimeters, and you can do that very comfortably. The other option is don't use that, except that you're going to put a cemented stem in, translate the whole knee replacement, put a very, very skinny stem in, which is cemented, put it up in the low demand patient. Therefore, even though the stem, the shaft is here and the femur is here, you can still sneak the stem up, cement the whole thing into a big metaphyseal, and you can get away with it in that scenario with a short stem. So the link is the classic example of a very thin spike that you can put up, and in that scenario in a low demand patient you can do that too. Obviously a very big cement mantle means that it's likely to get loose, so that's not an implant that's going to last 10 years. That's an implant that will last you 2 to 3 at most in a low demand patient. So that is your elderly, high comorbid, not very mobile situation. But if you want good fixation, then actually in that scenario, distal femur is probably better. Prox tibia, much harder, bigger morbidity, extensor mechanism needs to come off, lots of soft tissue stripping, might need a plastic surgeon to cover the defect because obviously you haven't got bone over the front or the side. So it's a much more morbid operation of proximal tibia. A distal femur, I do very often for distal fractures, and my patients leave after 3 days, fully weight bearing, treat them like a primary knee, and they do very, very well in the elderly, where I'm not concerned about it having problems in the future.
Yes, you said, sir, in your talk, I have to be cautious about the length of the femoral stem. So I do not introduce an iatrogenic fracture. Yeah. What's the maximum length allowed in your opinion?
So for me, when I use sleeves quite a lot because it makes my life very simple. I don't have to worry about dialing an offset, trying to create the angle. The sleeve goes straight down and my stem goes straight down. It's all based on the intramedullary axis. So actually, I use very short stems. So my general stem is 6 centimeters. It's very short. The issue with the stem is less the length, but more the diameter. It's difficult to draw, but essentially the femur is curved. So when you put a long stem in that's big, it will engage, and generally you have a defect anteriorly. So when you put a big stem in, it tends to engage with the bow, and the whole component lifts anteriorly like that with a big stem. Whereas even if you go long and you go narrow, then it will still bypass the curve and almost get 3-point fixation, and you can still get it straight. But the minute you go big, the stem will naturally do this because you always have weakness anteriorly and the whole femur lifts up, particularly with a sleeve. It does that a lot because you're relying on intramedullary alignment to put your sleeve in the right place.
Yeah. For the tumor prothesis, I have a case. It was in the conference the last week. She's osteosarcoma and she had a tumor prothesis, and it's infected, unfortunately, about 3 years of infection. What's the options for revision?
So again, it's that the discussion is function for the patient. The simplest thing when I do that is if it's generally a high functioning patient, I essentially I do a single stage, but I loosely cement in a tumor prosthesis, a cheap one. Okay, so your link, rather than an expensive modular big tumor prosthesis, I use a non-modular standard length, and I then wrap it in cement. So I do a radical debridement.
Single stage.
So do you know what a kiwi hip is? We call it a kiwi hip. We put an Exeter stem in, loosely cemented, but sometimes those last for 10 years. So I do similar. I do a single stage, 2 stage, if that makes sense. So I essentially cement up, but loosely at the top, and then I wrap the whole prosthesis in cement or antibiotic, whatever I want, to cover that area, to dilute antibiotic to that area. And I use it as a spacer / functional articulating spacer. And then if they get away with it, then I never go back in and I leave them with that. If they're a bit loose at the top, then I can always go back in when the infection is cleared and then revise it. But I know it's slightly not cemented well at the top. Therefore, I can then go in and put a definitive femoral stem in, proximal femur or distal femur, whatever it may be, at that stage once I've cleared the infection. So I usually use a non-expensive tumor prosthesis as a spacer, basically, and wrap it in cement.
For the hip, sir, sometimes in inoperable cases, we go to the resection arthroplasty and girdle stone operation. But what for the knee?
So the knee is difficult. Basically, in the knee, the salvage is amputation. Fusion is fine, but generally they're short. They have issues. They don't like it. If you're doing a fusion Generally, it's in a revision situation already. They've had a primary, then they've had a revision, then they've had another revision. By that stage, the bone stock is not 2 or 3 centimeters. It's an 8 centimeter gap. So by the time you've shortened and fused at that scenario, it is very short and it's a non-functional limb. So then you've got the decision of, do you fuse them, use a frame and lengthen them? And again, that depends on the age of your patient. But in most patients where you're doing revision arthroplasty, thinking about arthrodesis, the honest answer is an amputation is a better operation for them.
Yeah. Dr. Ahmed, any questions to Professor Nawaz?
No, I think I have got many tips from your discussion, Prof. Muhammad. Thanks so much. Thanks so much, Mr. Nawaz. I think it has been.
Thank you so much, sir. At the end, I would like, from the bottom of my heart, to thank Professor Zuhair Nawaz for his very, very kind participation for the second time with us in the course. Thank you so much, sir.
Always a pleasure. Very happy to do it again.